Good morning. Good morning, facilitators. Good morning, respected senior colleagues and colleagues. My name is Dr. Maduka. I'll be taking practice question 10. The question is as follows. A 26-year-old hairdresser known to have a seizure disorder for 4 years, involving focal with secondary generalization. She was on phenytoin, but control was poor. The physician added sodium valproate about 3 months ago, and the seizure has been controlled, although she does not strictly adhere to her medications. She recently got married, ready to start her family, but she is concerned about the possible effect of her illness on her reproductive life. The task is to counsel her about her concerns about reproductive life and the medication and also the disease condition. All right. Good morning, ma.
Good morning, sir.
Dr. Maduka,
my
we
name-
need it someone to, or Dr. Kalamama or Dr. Okele, one of you can be his timekeeper to keep reminding him of the time.
Okay. Dr. Kelly is already doing that, ma'am.
Okay, fine, that's
you.
perfect. Go ahead.
Good morning, ma. My name is Dr. Kurafo. I've been asked to have a discussion with you about your health condition. Can we go ahead with that?
Okay, sir.
All right. Are you comfortable here? Can we have the discussion here?
No, it's okay. I'm fine.
All right. Can I offer you a drink, water?
No, thank you, doctor. I'm okay.
All right. I don't know if you came with someone. Is anybody who want to join us in this discussion? But I will remind you that we may have to discuss some personal and sensitive matters here, if you don't mind.
We can start the discussion, sir.
Okay. Thank you. Please, may I know your name, please?
My name is Mary Joseph.
Okay. How old are you, please?
I'm 26 years old.
All right. I was made to understand that you've been having jerking movements of your body for about 4 years now, for which you were commenced on some medications. Is that correct?
Yes, sir.
Yeah, I'm really sorry. I'm really sorry for this. I can't imagine what you're going through. I'm very sorry.
Thank you, sir.
All right. The drugs you were commenced on, are you taking them as prescribed and as regular as possible?
I'm taking it now, sir.
Okay, but do you take it regularly? Have you been taking it regularly?
Yes, sir.
All right, fine. If you don't mind, I'll have to ask you a few personal questions, please. Do you take alcohol?
Once in a while.
All right. Do you smoke or use any recreational drugs like cocaine?
Not at all, doctor. No.
All right, that's okay. I don't know. Is there anything you can tell me about this condition you have? Can you tell me a little bit about what you know about this condition, please?
Okay. Since I've been coming to the hospital, they've been calling me seizure. But what I notice is that my hand will start shaking, and then before I know, I will not know where I am again. By the time I will wake up, they will start telling me what happened. That all my body will just be shaking, and then it will stop on its own. Almost 4 years now it has been happening, but it's better now. It's better now since I started the other drug the doctor added some months ago. It's better.
Okay, I'm really sorry. Okay, I'm really sorry. But before we go ahead with this, is there any concern you may want me to address while we discuss this?
What do you mean, sir?
Okay, first of all, would you want me to tell you more about this condition?
Yes, doctor.
Okay, are there any worries you have that you want me to discuss as we go ahead with this meeting?
I might have some questions I would like to ask.
Okay. As often as the questions come to your mind, you can let me know, please.
Okay, sir.
So this condition you have, which is the jerky movements of the body, is what is called seizures, and sometimes we also refer to it as convulsions. I know you've heard about that before too. So that is just the jerky movements of the body that you're experiencing. Usually information in the brain usually carried, we can describe it as being carried through what we can say look like wires, in the brain in the form of electrical activities. And so when this activity is excessive, when it is very excessive, that is what can lead to these convulsions. And it's worthy of note that for a large number of people that have this condition, we may not be able to really say what the cause is. But for few people, the causes can range from a swelling in the brain, people that maybe take alcohol or engage in use of recreational drugs. And also, apart from this, people that also have this condition will also have what we call triggers, things that they are exposed to that will make them have these convulsions very often. So these triggers can range from being in a lot of stress of any form, or being in a place where there are flashes of light. So it can make them have this condition very often. And the truth is that usually we're able to confidently say that this is what someone has, as in your case, based on what we were told, either by the patient or by an eyewitness. So we can say for sure that the patient has convulsions. However, in some few percentage of people, we will have to do certain tests for the patient, which could range from a brain scan to doing certain blood tests. I don't know whether you can recap some of the things I've said just now, please.
Okay, you said it's also called convulsion, what I'm having. And it's, because some wires are not conducting well in the brain. That it can be caused by either when the brain is swollen, Abi? And that there are some things that can trigger it, which I've noticed in my own. If I'm very stressed, that's when it comes up. It's true. That one is true. So that's what you said.
So you have 2 minutes more.
Okay, thank you very much. Usually, the good thing is that there are some drugs that we can use to control this condition, but you will have to take them regularly. And
I'm
also,
taking them now. Yes.
okay, you have to take them regularly, but you have to have in mind that some of these medications can make you feel dizzy. You can have your heart beat often, and if you take them while you're pregnant, okay, it can also cause abnormal development of the child in the
That
womb.
pregnancy is what I want to ask about since you brought it up now. And that
Oh,
pregnant, I just got married. Can I be
yeah.
pregnant while I have this condition?
Yes,
The drugs
people
affect
that
my baby if I get pregnant.
yes, it can. But that is why, for now, while you're on this medication, it is advised you are on some form of contraceptive, something that prevents you from being pregnant for now. And I advise that you be on a device that we call intrauterine contraceptive device, which they will put, inside your womb, and it will help prevent the pregnancy for now.
No, doctor, I
However,
want pregnancy. I don't want to prevent it.
okay, I understand that, but you've not really had a very good seizure control. And if you get pregnant now, when the seizures have not been properly controlled, and you're not even taking your medications regularly, it can affect you, and also it can affect the baby. The plan is that if you're on these medications for now, and we're able to achieve very good seizure control while you are compliant on these medications, we can now begin to plan for your pregnancy. What we'll do for you is that we'll have to withdraw these drugs that are not safe in pregnancy now, and we can introduce the medications that are safe for you and the baby. in pregnancy. And then we also have to involve the services of, okay, we also have to introduce the services of a doctor that can also take care of people that are pregnant or are planning to get pregnant, that will help us also manage you during this period. So I don't know if you can recap some of the things I've said now.
I understand you, doctor. Like, how long now will this take, this waiting before getting pregnant?
Okay, like I was trying to say, we'll have to start you on these medications, and while you're on the medications and you are compliant on them, and these seizures have been controlled for a while. There's no particular timing. We now begin to plan for your pregnancy. It's not right to just get pregnant like that while we are not really sure whether the seizures have been controlled, very well, so that you don't have these convulsions while you're pregnant, that it will also affect the baby. So that is why we want to take it this way. And like I said, we also involve the services of an obstetrician, a doctor that takes care of people, that are pregnant or that want to get pregnant. And so he will also help us to manage you properly as the time goes on. So that is the reason. And I don't know, if you have any other concern, you can also let me know at this point, please.
Okay, sir. Thank you, Sam.
Okay, in summary, I've been able to tell you what the convulsion is, which is the jerky movement of the body you're having. I've been able to tell you some of the causes, which could include use of medication, use of or somebody that takes a lot of alcohol or use of recreational drugs. We've been able to talk about the fact that these drugs can be controlled properly. This condition can be controlled properly with medications, and that you have to be adherent to it. And that the drug, this condition, when you have it, when you're pregnant, if you have seizures while you're pregnant, it can put you at risk and also put the baby at risk also. And you know that if you have this condition while maybe you're cooking, you can get hot. So that is why we want to ensure that you're on this medication as much and as exactly as prescribed. And so after we've been able to achieve good seizure control while you're on these drugs, and mind you, like I said, you also have to be on some form of contraceptive to avoid getting pregnant for now. When we've achieved very good seizure control while you're adhering to the medication, we involve the services of an obstetrician, like I said. We remove these drugs that are not safe for you. Thank you very much.
Okay, well, thank you so much for the detailed presentation. So, thank you, Dr. Nela. Okay, so now we'll take comments from the participants first, and then we'll move over to our teachers.
Okay, good morning, senior colleagues and colleagues with facilitators as well. Okay, and thank you so much, Dr. Maduka, for that beautiful attempt. I don't know, please, can you take us back to the question, please? Thank you.
Okay.
Okay, so, okay, it's saying that the physician added sodium valproate about 3 months ago, and the seizure has been controlled, although she's not strictly adherent to her medications. Okay, so here it's saying the seizures have been controlled. Okay, so I don't know, should she still go ahead to get pregnant? Because I heard when you were saying that the seizures are poorly controlled. It's controlled, but just that she's not taking her drugs regularly. So I don't know whether maybe that can be revisited, like telling her not to get pregnant at the moment. I don't know, Dr. Madika?
Yeah, I can hear you. I noted this part, but my thinking, I don't know, the neurologist can come in. I felt that, yes, although it is controlled, but she's not adherent. So I felt we'll have to address the issue of adherence why she's on this drug, so that and let her know that she can't just go and get pregnant. We'll have to plan the pregnancy. So by the time we've decided, we've seen that she's adherent to the medication, even though she continues to be seizure free, we can now switch over to medications that are safe in pregnancy. If we don't address the issue of adherence and we switch, she may continue and we switch and encourage her to get pregnant. So my thinking is that she may continue to be she may continue not to be adherent to the medications, minding that in pregnancy, the body physiology changes, the drug concentration may not be the same, especially when you're even changing to a newer drug. And if she continues not to be adherent, okay, she may have decisions subsequently. That was my thinking for this question, but I welcome more contributions, please.
Okay, thank you so much. Okay, my own thoughts. I think.
No, Florence, go ahead.
Okay, sorry, dear. Okay, my own thoughts. I was thinking you can actually tell her to go ahead with her maybe trying to get pregnant, but you emphasize on adherence to medication. And then also tell her that at that point in time, an obstetrician has to be involved, whereby the moment she gets pregnant, they will switch her medications to safer drugs. They want her safe in pregnancy. So that's what I was thinking. And again, secondly, I don't know, did you invite her husband, her spouse, to be part of the conversation? I don't know if I heard clearly.
Okay, I noted that note at the foot of these questions. That was why I actually just asked generally if there was any other person she would want to be part of this discussion, but I didn't specifically mention the husband. So I felt maybe if the husband was around and she wanted him to be part of the discussion.
Because I think in the management, her spouse should know about her condition, because it will help her also in her management. Because I think there's a part where they said the spouse was around, but she wasn't going to tell, So I think it's advisable her spouse should be aware of her condition, because that will help. Okay, then in counseling her about the seizure disorder, did you mention to her about her do's, her don'ts, and when she should see a doctor about the disease condition? Because that would also help her in having a good control, a good seizure control. Did you mention? Sorry.
No, I didn't mention do's and don'ts.
Yeah, I think that should have been part of it. Thank you so much. Thank you. It was a beautiful attempt. Thank you also, Dr. the participants. Thank you so much. Thank you.
Thank you.
Thank you so much, Dr. Florence, for that beautiful addition. So, Dr. Binte, please go ahead.
Okay, thank you. Good morning, teachers. Well done, Dr. Maduka. It was a beautiful attempt. So, I want to address the issue of seizure control before pregnancy. I agree with your opinion, because according to the question, the seizure, she has poor drug compliance and the seizure is not well controlled. So preconceptional counseling, one needs to advise patients
sorry,
to delay.
actually they said has been controlled.
Okay, did they say has been controlled?
Yes, they say has been controlled. That's the controversy here.
Okay, all right. So the seizure has been controlled, though she's not strictly adherent to her medication. So there's this preconceptional counseling that is given to female patients with seizures. So it's advised that they delay pregnancy till the medication is valproate is teratogenic, is the most teratogenic of all anti-seizure medication. So we want to tail off valproate, introduce a safer medication in pregnancy, achieve good seizure control with the safe medication before she's advised to get pregnant. So now that she has good seizure control, we want to gradually tailor valproate, introduce drugs like lamotrigine and levetiracetam, which are safer in pregnancy. achieve good seizure control before she's now advised to get pregnant. And really, the management is multidisciplinary. The obs and gyne team will be involved. Her husband too will need to be carried along. Then, once good seizure control is achieved, preconceptional folic acid use, then early pregnancy, then the drug needs to be monitored even before pregnancy, then during pregnancy, because the dose of the safe medication might have to be increased in pregnancy because of the physiological changes that happens in pregnancy. So higher doses of this safe medication may need to be introduced. Thank you.
Thank you very much.
Thank you.
Thank you so much.
Yes. Okay, Mark, please, you have the floor, Dr. Jamila. Hello, Ma.
Good morning, all. Sorry, it was difficult because of the network problem, I wasn't able to unmute initially. I wanted to talk about the valproate, as Dr. Pimpe has mentioned. I think the caveat here, the main problem here is the valproate, not the poor seizure control, though they mentioned that there is significant control with a seizure medication. Seizure control, though not quite compliant with the medications. So as Dr. Bimpe mentioned, lamotrigine and levetiracetam are the safest, lamotrigine in particular. But however, there's another caveat using these drugs. During pregnancy, metabolism of both drugs increase. So trough levels need to be measured throughout pregnancy, initially monthly and then 3 monthly before the woman delivers, because it needs to be increased, I think monthly or even per trimester. That is both the lamotrigine and levetiracetam. So apart from weaning the patient of valproate, introducing lamotrigine and levetiracetam needs to be monitored. So she needs to know about that. And I don't think it's wise to tell her that conception needs to be stopped now, because women with epilepsy, most of them have reproductive abnormalities, ranging from infertility to PCOS. So it's not wise to tell her that, no, you can't conceive now, because that is one of the major challenges they face. So maybe it's safe to tell her that, okay, it's going to be very short. We are going to wean you off the valproate, introduce a new drug, make sure that the seizure is still well controlled, and then allow you to conceive. And the safest contraceptive method she can be placed on is IUCD, because of the easy reversibility and does not affect the contraception AEDs she's going to be taking, because even the contraception is quite challenging in patients with epilepsy. So the safest is plain IUCD that does not have the hormones. We know that estrogen metabolizes AEDs. So you can't give her any contraceptive that has estrogen in it. Rather, you can give her progesterone, only pills, or plain IUCD. Because of the easy reversibility, it will not affect her AEDs, and then she can conceive subsequently when the valproate is weaned off. Thank you.
Thank you very much.
Thank you.
Thank you.
Hello, Dr. Florence. My network is so
I
poor.
can hear you. I can hear you. Okay. Do you need help?
Yes, please. Please.
Okay.
Hello?
Okay.
Hello?
All right. Hello.
Hello?
Okay, you can have the floor. You can have the floor, Dr. Agbo.
Please, my own is a clear. Good morning, facilitators. Good morning, everyone, please. My own is a little concern about the question. Forgive me, I might be taking us a little back. I want to understand this particular station on counseling. Is it about a preconceptional, is it like we're telling the woman not to conceive now? Or is it that we're telling her go on with your life while adjusting your medications if you get pregnant, whether you get pregnant or not. Please, that's why my question is, because is this really more like telling the woman to hold on with conception, or is it go on with your life? If you conceive, fine, we'll adjust your medications.
Okay, thank you so much. Okay, Dr. Maduka, if you have the floor, then if you can't, then the neurologist can help out. Thank you.
Thank you very much for the question. My thought initially was that yes, we've been told that she's achieving good control. However, she's not adherent to the medication. So my thought was that, okay, she has to continue with the medication for now and ensure that she doesn't get pregnant now. And then by so doing, make sure that she's adherent. And when we achieve this adherence, which is very, very important, we can now tail off the medication and introduce the one that is safe. Of course, involving the services of the obstetrician. So we have to plan the pregnancy. It's not something that she should just accidentally get pregnant, even while on the valproate, considering that its teratogenicity can even start at the very earliest stage of pregnancy. But my understanding now from the previous contributor is that we should just, regardless of her not having the proper adherence to medication, as long as the seizure is controlled now, that we can begin to tail it off now. So the contribution from the previous from this previous speaker is more like it is not. We shouldn't tell her to stop, not to get pregnant. She should just go ahead with her life, and then we just change the drug. So that's my understanding now, which is in contrast to the thought I have when I took this exercise. So
Okay, thank you
what
so
I
much.
understand.
I think maybe I might differ. Or maybe I want to align with you, because I think I agree with you that yours is the best for this woman. The woman needs to be stable before we start thinking about conception. We need to have a way of removing the sodium valproate before she can be allowed to conceive due to teratogenicity. So I think this is more of a preconceptional counseling station. That's my own opinion. Maybe the neurologist will tell us different.
Dr. Kalamama, I think Dr. Yusuf, his hand has been up. I don't know if he's a neurologist. Let him come in, then the facilitator also will go around the circles.
Okay, okay,
Just have to come in.
Okay, thank you so much. Okay, so Chief Yusuf, you can have the floor, please. Thank you.
Okay, thank you very much. Thank you, my chiefs. Good morning. So I'm not actually a neurologist. I just noticed while the Dr. Maduka was presenting, because we've been talking about this issue of non-adherence, but I feel he was not able to actually address that issue of non-adherence while doing the discussion with the patient, because it's important for us to be able to know the perception of the patient, because many people, their perception regarding seizure disorder, they have a lot of perception.
Sorry, you are a bit distant. You're a bit distant from your device, so we can't hear you very well.
Okay, sorry, am I audible like this?
You're better now.
Better? Okay. So
Yes.
I feel he was not able to really address the issue of the perception of the patient. Some people will have a lot of spiritual perception regarding this illness, and that may be the reason why the patient was not actually adherent to the medication in the first place. He took some few biodata from the patient, he took the symptoms, but he was not able to even ask the patient, do you even know the cause of this problem? What is your perception about it? Because if that perception has not been addressed, it's even difficult for the patient to be able to adhere to the medication, because that's actually what we have been discussing now. So if you're able to get the perception of the patient, I think it's important. We'll be able to address, and patient may be able to adhere. And whatever medication we want to, either want to taper, want to introduce another one, patient will be able to comply with the medication. Then when you talk about the etiology too, They talk about some, of course, they didn't mention about trauma to the head. It's a common thing that we know can be a cause of seizure disorder. Perhaps maybe the patient has ever had RTA in the past, any fall from height or something like that. Because they did not include that too as part of the etiology too. So that's just a few contributions I want to add. Thank you.
Okay, thank you so much. I don't know if the neurologist, we have a lot of questions on the chat room. So what we basically do, maybe we will screenshot and send to the group later for more contributions. So I don't know if the neurologist can also help out to conclude on this particular question as regards questions have been brought up. Chief Jamila, Chief and Dr. Binky, to just conclude on this. Thank you.
Hello. Hello.
Yeah. Hello.
Okay, so Dr. Agbo, you notice neither myself nor Dr. Jamila said she should go ahead with her life. So what we said is that she should delay pregnancy for some time till she's able to achieve good seizure control, and the valporate is weaned off, gradually tailed off, and a safe medication in case of lamotrigine or levetiracetam is added to her medication. And even during pregnancy, even before pregnancy, the blood drug level is being measured, and it's also being done monthly in pregnancy. It would be very risky to ask her to go ahead with her life, because if she gets pregnant unintentionally and she's still on valporate, the risk of teratogenicity is quite high. Reproductive issues in female with epilepsy is very, very important, and one needs to be it has to be a multidisciplinary approach involving the up and gyne, the patient herself, her close relatives, likely her husband, and the neurologist, because every stage of their life is being reproductive life is being affected as a result of this seizure. So even contraceptive, like Dr. Jamila said, there's a specific type of contraceptive that is safe for her to use, that would work well, which is in the form of IUCD. Then pregnancy, drug levels should be well monitored, because some of those drugs may need to be increased as a result of the physiological changes in pregnancy. Thank you.
Thank you so much. Thank you so much. So we'll move over to our chiefs in the house. I can see Chief Remigo's hand and Chief Chitu's hand. Chief Remigos, you can please have the floor. Thank you so much.
All right. Thank you so much. Hello?
Yes,
Hello,
sir, we can hear you.
All right. Please use the other person talking. Let's meet the person. All right. So thank you. Counseling stations are always very interesting, okay? And usually, as Chief Shit will always say, you can get all your marks and then you can still get 0 marks. So let me just wade into this discussion first of all, before I make my other comments. So yes, one very important thing about counseling session is that your thoughts are usually, they're not always wrong or right. It usually depends on how you're able to put out your thoughts and make it, put it out, and because people will be listening to you. If you are making complete sense, no matter how you are putting it, you are likely to get your marks. Everybody cannot say exactly the same thing. Okay, so like the issue of contraception, the issue of pregnancy and all that. I think the most important thing here is to realize that, one, the patient needs to be put on medications that are safe in pregnancy. Two, you must appreciate the fact that contraception or that pregnancy or fertility issues occur in this background of seizures and use of anti-seizure medications. Okay, so you must realize that and then pass this message across to the patient. In fact, you could also use that to make her to be compliant. The fact that she wants to be pregnant. So that will be like a motivator, something that will motivate her to become compliant. So you could use that, okay, even in your counseling, to make her to become compliant with medications. But it's very important that you start thinking about changing her medications to those that are safe in pregnancy and contraception, as in pregnancy, as soon as possible. In fact, if possible, immediately. Okay, so start thinking of weaning her off those ones that have high teratogenic effect, and start and change her to the ones that are better in pregnancy, or better tolerated in pregnancy. So I think those are the key things. Okay, so of course you need to explain the dangers, because no matter what you say, you remember, I was listening to Dr. Agbo. Please, we are no longer practicing paternalistic medicine. It is the patient that decides. You can say all your dogontirench and the patient still says, I don't care, I want to get pregnant. And there's nothing you can do about that. The only thing you can do is to see how you can help her. Okay, if you want to get pregnant now, let's do this, let's do that. Let's get the gynecologist involved. Let's try and win you off this one. Let's do this. So that's how it should go. It's not about you. It's about the patient. But your job is to give her all the information she needs, okay? So give her the right information, the best thing to do, the best way to go, and then allow her the available options and choices, and allow her to make her choice. You can tell her that, oh, delay pregnancy, and she says, no, sir, I don't want to delay pregnancy. Okay, and there's nothing you can do about that. So you just will have to work with her, okay? So I think that's my take on that one. But I wanted to talk about the presenter itself. Yes, the presenter, I loved the way he started. It was really, the setting was beautiful. Just that he missed out about that husband part. Okay, this person is just newly married, and she's talking about getting pregnant. You know, she's not the only one that will get pregnant or get herself pregnant. Her husband has to be there when you want to talk about issues of contraception and all that, and the issues of pregnancy and all those things with the wife, unless she expressly says, no, I don't want him to be there, because a woman has a right to decide whenever, however she wants to get pregnant and all that. Yeah, she completely has that right. But you need to offer that it will be good if your husband is here, so that he will assist us in doing this, because many of the things that we want to do, his input will be very important. And then she now says, oh, he's outside, or can we call him? Or she now says, no, don't worry, I will tell him later, or whatever. So it was quite important that you mentioned that. But then your empathy was beautiful. I just felt that maybe you didn't find out her level of education, even though you didn't use big terms, but your grammar was big, but you didn't use highly technical lingo most of the time. You tried to simplify it. So it was good. Now, another thing I wanted to point out is always remember the question. Never forget the question you're supposed to answer. Here, the question you're supposed to answer is, she just got pregnant, or she just got married, she wants to get pregnant, and she wants to know how the medications and her condition can affect this. That's the first most important question. Okay, so even when you're asking about her consents, you want to tease this out. Is this her consent? Does she have other consents? Okay, so I know you tried a little bit about that, but please don't waste all your time talking about all the etiology, all the causes. You took a lot of time going into details about the condition itself. But the question was trying to, link the condition to her desire to get pregnant. So I felt that that's where you should have dwelt more, okay, than the other places. Then, yeah, some people talked about the social aspect, which is also good. Okay, so these are just the things I wanted to point out. So thank you so much.
Thank you very much, sir. Thank you.
Okay, thank you so much, Chief Remigos, for that great input. So, Chief Shitu, you have the floor, please. Chief Shitu. Chief Shitu.
Yes, good morning, everyone. Yes.
Good morning, sir.
Presenter, yes, you've done well. But I just want to ask one question. What was your task here?
Okay, my task here was to address her concerns about the effect of the drug on her
Okay.
reproductive life.
Good. And that was the task. Now, if she hasn't been using the drug as prescribed, okay?
Sorry, it wasn't just the drug, the drug and the disease condition.
And the
And the
disease.
disease condition. Yes, lovely. Now, when answering such a question, counseling sessions and the rest, please do not forget the fact that the most important person is the patient, not the disease condition, but the patient. Okay? Because I am sure that the way it was set up, this is not the first time she's hearing about seizures. Okay? Yes, they do want you to tell her about it again. But I think the major thing here is that she's not been compliant. Question is why? You really have to fish out why. Because the truth of the matter is her non-compliance may be because she wants to get pregnant. And that may just be the catch in the whole question. Okay? So
yes, sir.
The most important thing is to figure out her concern. But she started a drug. She's been doing well with the drug. But she's not using the drug like she should. Why? Is it because she believes the drug is not the one doing the work? Or is it because she wants to get pregnant? Okay, now if you get that problem sorted out, you don't have to be a neurologist, you don't have to be, and you just have to be a physician to be able to tackle this thing. So the most important thing here is to figure out what her concern is about taking the drugs and why she's not compliant. Because you can do all the nice things we've been saying here since morning, and she won't, like Dr. Remigo said, she won't answer you. She'll do anything she wants to do. Okay, so it's important to figure out what her issues are, particularly in something that she's been taking drugs over. You've seen the fact that they want you to invite the husband in. Because, of course, when you're setting the scene, you're going to ask her, is there somebody here with you? Did you come alone? Is there somebody else you want to have this session with? You know, and oh, my husband is outside. Call him in. You understand? So if you sort out that, that tells you instantly that they want you to talk about reproductive life and what it's about. You also need to find out things like, oh, how many children do you have? Oh, are you desirous of children? She may not say she doesn't have kids at all. Oh, do you want children? Or are you hoping for children? And the person tells you yes, you know that, okay, this will be why she's not taking the drug. Even if she says she's had children before, how old is your last child? And she tells, and next question will be like, oh, have you stopped? Have you had enough, or you still want to have more? No, I'm still trying to have more. You know that you've been teasing out the issues surrounding why perhaps she's not being compliant with her medication. And then when you sort out all of that, you can now decide on what you should do. If she tells you, look, I want to have children, all this one you guys are talking is over my head, that's why I'm not using the drug, then you have to switch her to a medication that is safe. That is the truth. You have to switch her immediately. Now, if she tells you, oh, I don't want to have children, and this is it, I'm not taking the drug because I don't believe the seizures, I believe the seizures are spiritual. Okay, fine. You have to cancel her and let her know that, look, the drugs are important and the consequences of not using the drug and things like that. Then you can now say, oh, but since you're on this particular drug, these are the pitfalls. So she could say, oh, I'm not totally off the idea of having children, but maybe I still want to have children in the future and things like that. Then you can now offer her various forms of contraception depending on what she wants to choose and things like that. I'm sure in each of our specialties, we have peculiarities like this, that you have a pregnant woman that's supposed to be on a medication that is not safe during conception and the rest, that you have to switch them over. And these are the things you have to plot out. But anybody of reproductive age that is married, you have to be sure that what are their wishes when it comes to their reproductive life, and then sort it out. Okay, that's also what I wanted to add. But please, let's not forget that the most important person is the patient that is in front of us. And you must be seen to be focused towards the wishes of that patient, while giving them, of course, good information so that they can make good decisions. Thank you.
Thank you very much.
Thank you so much. Thank you so much, Chief Shitu. We have quite a number of questions in the chat room, so I want to find out from the chiefs. Should I go ahead to read the questions? We have quite a number.
Please, yes,
Chief Peter,
what is not doing is not doing well. So this is the first time we're taking a
okay.
counseling station, so we should go ahead and answer all the questions.
Okay, thank you so much, Chief. Okay, thank you so much. Okay, so I'm going to read. A lot of people are applauding you, but I'll just go straight to the questions. Okay, so Dr. Neka is asking, what is the time interval to say the seizure is controlled? Dr. Madika, please, what is the time interval to say the seizure is controlled?
Okay, there's really no time interval actually, but the catch here is that, like I said, the patient is not adherent. So I'm thinking, okay, even though the patient is not adherent, it's important to make it clear that she has to continue to take the drug. So if that there is a time interval to say that the seizure is controlled is in the setting of this question is what I don't think there's a particular timing to it. It's just to ensure that the patient is adherent for this question. But I'm aware that in people that are epileptic, usually when they've had the drugs and they've not had seizures for 2 to 3 years or thereabout, you can begin to consider tailing off the medication. So, but in this particular question, there's no rigid timing to say, okay, after you've taken it for 1 week or 2 weeks, we can say it's controlled now. Decide to switch. So that's my reply to that question.
Okay, thank you so much, Dr. Maduka. I don't know if the neurologists, they have an add-on to that. Neurologists, do you have an add-on to that, please? All right. Okay, so I would go over to the next question. Thank you so much, Dr. Maduka. Okay, so the next question is saying, well done, Dr. Maduka. It will be good to plan follow-up for talks, provide materials on information on epilepsy and pregnancy. It is also important to know the reasons for non-compliance, the side effects, the costs, etc., as the risks for seizures may be higher during pregnancy. Then another person is saying, the next person is saying, thanks for the wonderful presentation. I have a question to the statement made earlier by Dr. Florence. Does the doctor have the right to divulge information concerning her patient to the spouse without invitation, consent by the patient's autonomy? Okay, so what I actually meant by that was it would be nice to be advisable for the husband to be part of the management because it will help also in the seizure control. Yes, autonomy is very important. The patient's decision actually stands, but it will be advisable the husband is part of the management. Thank you so much, Dr. Laniko. That was what I meant. Thank you. All right, so Dr. Agbo is saying, so it is a preconceptional counseling. That he said he feels is a preconceptional counseling. Okay, so Dr. Mbapita is saying, is the focus, good morning, senior colleagues, is the focus on the sodium valproate alone? What about carbamazepine? Will you consider starting her on lamotrigine or levetiracetam as a single therapy or an add-on? So he's trying to ask, are we just focusing on sodium valproate? What about the carbamazepine? Are both of them not teratogenic? So are we going to consider starting lamotrigine or levetiracetam as a single therapy or an add-on? Okay, Dr. Maduka, you can please have the floor.
Thank you very much for that. Thank you very much for that question. Actually, it's phenytoin and sodium valproate, and both of them are teratogenic. So I'm talking to a patient that is a hairdresser, so I just assumed that the level of education is not up to the level where I would just call the names of the drugs. Yes, we'll have to tail off these drugs. And I know that there's a pattern to tailing it off. you reduce by 10% in the first 2 weeks. Next 2 weeks, you keep on reducing it that way until you're able to tail it off. And while you're tailing it off, you now introduce the drugs that are safe, like our chief mentioned, the levetiracetam or the sodium or the lamotrigine. But you start with a single therapy. That's the general consensus about using anti-seizure medication. Is being advocated that you use just one drug, and then if the drug is not working, you can now introduce the second one while you even tail off the one that is there already. So assuming I introduce levetiracetam or lamotrigine for this patient and it's not working while I've gone to the maximum dose, I will start reducing it while I introduce the next drug with the aim of removing the initial one that I've added initially. So while the patient is on this drug and the second drug, probably levetiracetam, and is controlled, fine. That does it for the patient. But if it is not controlled, I know that there are other things you now have to do. You may not have to use the 2 drugs at the same time. But generally, it is a single, is monotherapy that is usually advocated for this, unless there's a reason to add another drug. So yes, the 2 drugs have to go, phenytoin and sodium valproate. And it is not just about the medication alone, like our chiefs have said. We are looking at the patient as a whole. So it's not just the medication, it also involves talking to the patient about the condition she has in pregnancy too. Thank you very much.
I also think that, this is Dr. Shitu, I also think that the focus of this particular question is, well, but it may give you marks for knowing the drugs. I don't know, but that is not the meat of the matter here. Even if you don't know the name of the drug, or you don't know which drug to switch the patient to, you can still get your near complete marks here, because all you have to simply state is that what she's taking now may not be safe in pregnancy. Okay? And yes, and what you want to switch to is things that would be safe in pregnancy. That's what you have to tell her. You don't have to give her the specifics. That is why you will still have to set up, at the end of the discussion, you still have to mention that, oh, we still have to meet again and do this and follow you up. We have to tail off the other one and introduce the new one. But it all depends on what she wants. If she doesn't care about getting pregnant, she may even tell you that, oh, pregnant, they removed my uterus 2 years ago. What are you worried about? All you have to do is worry about her not being compliant and sort that out, and then continue on whatever she's taking now. Do you understand? So knowing the name of the drug may not really change much. All right, thank you.
Dr. Shitu. Hello,
Yeah,
Dr. Shitu.
Yes.
Yeah. As part of the question, they actually stated expressly that she wants to get pregnant.
Oh, okay. If they say she wants to get pregnant,
okay,
that changes the whole thing.
Yes, as part of the question, expressly. In fact, she just got married and she wants to get pregnant. So she's worried about the effect of it. Yes. Okay. Yes. So, but yes, your point is very clear. In counseling section, it's not really your stuff that they're interested in. The stuff just carries very little mark. The most important thing is how you pass the information across. So that one is sacrosanct in all counseling classes. It's not about the amount of stuff. You can carry some mark, but the majority of the mark is how you pass your information across, not the amount of stuff you know. In fact, sometimes moving too much stuff can be a negative for you in counseling session.
Maybe detrimental to the whole counseling station, because people have finished counseling station and say, I moved stuff on that station, but yeah, the person didn't pass it. Because you missed out on the communication, the empathy, the ability to listen and things like that. It's very true. Thank you, Dr. Remigus.
Okay, thank you so much, Chief Remigus and Chief Shito, for your great input. Okay, so I'll move on to the next question. Okay, so it says Dr. Andrew Godia is saying, thank you, Chief, for the presentation. It's important for the patient to be on folic acid a very long time before conception. considering the nature of the medication. Thank you so much, Dr. Kudia. From that, Peter is saying it is important to screen with a combination of an ultrasound and either maternal blood or amniotic alpha fetoprotein testing at 16 to 18 weeks of gestation to rule out NDTs. Thank you so much, Dr. Mba. Dr. Binte is saying the idea is to delay pregnancy till good seizure control is achieved with the use of IUCD. Okay, Dr. Adedapo is saying, thank you for your presentation, Chief. I think we have to get a well-controlled seizure seizure on the new medications with good compliance before she gets pregnant. Also, general counseling on seizure, including not take under the shower and other triggers. So she's talking about the do's and the don'ts. Okay, so Dr. Shaibu is saying, thank you. Please, are we tailing off the valproate and introducing the lamotrigine immediately? I think that has been answered. Okay, thank you so much. Okay, Dr. Momodu is saying, risk is dose dependent. A threshold dose below which no risk exists cannot be established. Valproate polytherapy associated with has been associated with increased frequency of congenital malformations compared with AED monotherapy. That is talking about the anti-epileptic disease monotherapy. So he's saying that risks of major structural abnormalities is greatest during the first trimester. However, other serious developmental effects can occur with valproate use throughout pregnancy. Thank you, Dr. Momodu. Peter Mbai saying it is important to screen with a combination. I think I've read this. It's important to screen with a combination. Okay, so Dr. Ojimi is saying good morning and thanks for the presentation. Educational materials were not offered to the patient. Thank you so much, Dr. Ojimi. I think these are all the contributions and questions being talked about or written in the chat room. Thank you so much. Thank you. Thank you all. Okay, so I'll hand over to Chief Christabel. Thank you.
Oh, sorry, hello. Sorry, Dr. Christabel.
Okay.
Before you go ahead, yeah, I just wanted to ask the presenter if he has any queries for us, for if he has questions for us, if there's anything clarification he wants to seek. I actually think he started very well, but I felt that he took too much time talking about stuff and instead of trying to address the question itself. But he did. His empathy was very clear from the outset, and his the way he talked about the way he set about commencing the counseling was perfect. So, but if you ask questions, you could ask so that will clarify. Thank you.
Okay, thank you very much. Thank you. Thank you to everyone for the contributions. The only question that I have, or the area I think that is still gray here, is should we stop the medication and switch, or should we tailor off now and switch to the new drug, or should we continue the drugs for now with contraception? That's just the only area that I'm having some confusion.
Okay, so let me try to address that. If any other person has comments, they can also go ahead and share it. So what I think is that the answer to your question depends on your interaction with the patient, okay? So we all know that the ideal would have been to achieve good seizure control, and the patient is also compliant with medications before you can now consider contraception, okay? So we all know that. But if the patient is now telling you that I don't want to wait. I want to get pregnant now. Your plan might have to change. So for me, I don't think there's a straightforward answer. I think you can offer that, okay, so, well, these medications you are on might not be very good in pregnancy. So, but if you want to get pregnant, we have to plan it. First of all, I want to see if I can wean you off these ones that might have an effect on your pregnancy or on your baby, while we gradually commence the ones that we think are safe. And then you have to be compliant on them. And when we have achieved good seizure control with you compliant on these medications, then we can now start planning you for the pregnancy. Okay, so, but she says, well, how long would this one take? I want to get pregnant now. Then you have to change. You have to be flexible. That's one of the qualities of a good counselor. Okay, so that's what I think is the answer to the question. I don't think there's any straightforward answer. Thank you.
Thank you very much.
This one that
Dr. Maduka, I think it's old and Dr. Maduka, I think we need to what I want to just say is I just like what Chief Remigo said. In this class, what we do is train you for the exam itself, so that no matter what you're faced with, you will not be muted. You always have something to say. Like for this particular patient, is depending on your communication skill as to it depends on the communication you achieve with your patients. I must thank Dr. Yusuf for bringing up the perception aspect. I think it was the one that brought it up. While that's what's going on, should he get pregnant, shouldn't get pregnant. He was one that brought that on up, and I must really appreciate him. Show that he was paying attention to the discussion. It wasn't distracted. So Dr. Yusuf Rahim, thank you so much for that. So it depends on your discussion with the patient. The patient is king. So when you are in exam, when you're in exam scenario, it depends on the patient. If the patient, you have communicated with the patient, told the patient all that's happened, what this is communication skill is what you are seeing in the exam, the feedback from the patient. If the patient says, oh, sorry, I didn't know, you've already achieved, known the reason why the patient has not been compliant, and you've addressed it, and the patient has promised you that, I didn't even know this, Allah now. I'll be compliant, I'll be taking my drugs going forward. Fine, that's the answer to that question. If patient say no, not now, in fact tomorrow, it's okay. So it depends on what your patient tells you. You work with your patient, but always communicate with them the do's and don'ts, the implications of their decision. Always carry your patient along, because these are the things they're marking. There's really no straightforward answer to this. So it depends on your patient. It depends on the scenario in front of you. Oh, sorry. So that is what I want to say. So I also want to reiterate what our dear Chief Remigo said. But overall, thank you so much. Thank you so much. It was a wonderful presentation from you. This is like your first. Oh, sorry. This is like your first presentation on counseling. And I love the way you started. I know you are going for this exam. So if you continue this way, because you build on, with all of us, nobody is perfect. The better we do these things, the better we'll become. So the more you counsel people, the more you do this, you keep getting better. Your skills will keep getting sharper. So I love the way you started. If you continue, if you continue at this pace, I'm sure when you exam, it will be very easy for you to just flow through. I love the way you were not rushing your words. You were, even though we advise you are cautious of time. So that's what I'll comment on. Please be cautious of time. We know you want to be empathic. You don't want to rushing your patient. So please, because there's a lot to say. So you want to be more conscious of time, subsequently speak a little faster, so that you quickly get feedback from your patient. And I also love the way you were asking her to recall all that you have said. You were carrying your patient. I love the way you are carrying your patient along in your discussion. So what our advice is, work on your timing, because in counseling station, focus on the task. Other things will become, you just quickly glance through them, but the focus is what you spend almost all your time on, and you continue to get feedback from your patient. It's the feedback you get from your patient you use to build on, because once your patient is satisfied, you've passed that stage already. Once your patient is satisfied, the examiners are satisfied. Patient is king in counseling station. So that's just what I wanted to say. So thank you, Dr. Maduka. Please keep up with this attitude. Thank you so much. Dr. Kalamama, thank you. Dr. Ekele, thank you. Thank you. Thank you. Then our teachers, Chief Chitu for his Chief Chitu has a way of making difficult things